We proceed to the next presentations, which is on perioperative techniques to minimize blood loss. This will be presented by Dr. Margit Kaufman. Dr. Kaufman specializes in the fields of anesthesiology, critical care medicine, and patient blood management. She received a Doctor of Medicine degree from University of Medicine and Dentistry, Robert Wood Johnson Medical School, and subsequently completed a residency in anesthesiology. She then pursued a fellowship in critical care medicine at Icahn School of Medicine at Mount Sinai, during which she developed a particular interest in patient blood management. Her research in this field has focused on optimizing blood utilization in critically ill patients, reducing unnecessary transfusions, and minimizing the risks associated with transfusions. As the medical director of the Institute of Patient Blood Management and Bloodless Medicine and Surgery at Englewood Health, Dr. Kaufman has led numerous initiatives aimed at improving patient outcomes through evidence-based blood management practices. Most recently, she has created a mobile and web-based application to improve compliance for patient blood management metrics and improve efficiency of the treatment for patients for whom blood transfusion is not an option. She has dedicated herself to advancing the field of patient blood management, improving patient outcomes, and promoting safe and effective healthcare practices. Dr. Margit Kaufman.
Good morning or good afternoon, where many of you are as well. I am so appreciative to the PMS Society for inviting me to speak today. Dr. J, phenomenal presentation. It was a great lead-in actually to what I do, because I see patients before and after those open heart surgeries. I'll start with disclosures. I do have a grant from the foundation here at the hospital for physician innovation, which I do use for patient blood management. So I'm a bit of a history buff, so I always think it's nice to kind of think about where we've come from and how did we get here. It would be important to note that actually today is the 61st anniversary of the first bloodless cardiac surgery performed by Dr. Duncan Cooley. And then kind of understanding where patient blood management has kind of come from here in the US and probably similarly repeated in other parts of the world. You have to understand a little bit of the historical aspects of what's happening. You know, starting in the 1980s, there was concerns about contamination of the blood supply, specifically in HIV. In addition, there was a growing literature coming out about what are the effects of blood transfusions on our patients. And that was actually something that was interesting to many of the surgeons here at Englewood, specifically the role of metastatic disease and mortality in patients who've been transfused. And this is all happening at the same time while there's a move from paternalistic medicine, where the doctor knows best and tells you what to do, to more of this aspect of that the patient should have control over their own care. And this is all happening. And at the same time, there's a growing religion here in the US and around the world, Jehovah's Witnesses and their leadership within Watchtower, which really felt that their congregants were not being treated appropriately, that they wanted high quality medical care. They just did not want blood. And they were reaching out to different institutions to see who would work with them. And the matchup of clinicians at Englewood who are interested in understanding, you know, but really we didn't know what we were doing with blood transfusions at that point and what were the effects of them. And this group of patients who didn't want to have blood transfusions seemed like actually a very good relationship to start. You know, starting on a small scale and then growing from by department. There were initial bloodless protocols started and, you know, multiple case reports and growing literature. And this is all actually happening at the same time of like restrictive versus liberal blood transfusion, the TRIC trial and such is coming out. With this growing literature that was showing that we could provide safe and effective methods for bloodless care and growing risk of over-transfusing really bore out this concept actually of patient blood management, that if we could focus on actually the patient's blood health, we're going to improve outcomes and quality and decrease costs for all patients. So I get to do some teaching, not so much. And I always like to start with a case for my residents. So I always start with this one just to kind of bring down this concept of perioperative patient blood management. So we have a 69-year-old female with known heart disease. She had a CABG 5 years ago, really hasn't been following up with her doctor, but she's here in my pre-op bay for her total hip replacement. But she's telling me she's had 9 months of tiredness, dyspnea, exertion. She can't walk through the supermarket without stopping, leaning on her cart. And I always have to sort of, residents, are we going into the OR today? And of course, right away, they tell me, absolutely not. This woman has known heart disease. She hasn't followed up. She's clearly at increased risk for serious cardiac complications, and she needs further evaluation. So then I change up the case a little bit and I tell them that they have the same woman, except that she just has a history of known moderate anemia and she hasn't followed up and she has the same symptoms of tiredness, dyspnea, and exertion. She can't walk through the supermarket without stopping. And she's here for her elective total hip replacement, and which they do. And then there's some hemming and hawing. Oh, well, you don't want to cancel the case. The surgeon might be upset, things like that. And I start to ask them, well, why do they think that way? Because there actually is literature that shows that they could be causing harm as well by taking a very highly likely anemic patient to the operating room. So starting back into the early 2000s, there was growing literature and smaller single center studies that were showing that even after you adjust for preoperative and perioperative confounders, including transfusion, that there was a clearly relationship between the level of pre-op anemia and the risk of mortality within 90 days. So this was a 2009 single center study. That blue graph is for men and red graph is for women, just looking at mortality. And moving up the hierarchy of literature, after you have your single center retrospective review, you go to your larger multi-center retrospective review. So this was in 2011, using the data from the National Surgical Quality Improvement data set, which had over 200,000 cases. This was showing that surgical patients who died had 1.42 times more likely to have been anemic, and patients who had complications were 1.35 times more likely to have anemia. And there was actually a dose-dependent relationship along the way. I just want to note that they called mild anemia here a hematocrit of 29 to 36. And actually, that would actually fall into some normal ranges in most institutions. And then you moved on to your prospective studies. This was in 2014. It was actually a secondary analysis of a large perioperative care and survival European studies that had over 30,000 patients. Interestingly, they actually had a lower level of anemia probably than we have in the US. About 30% of their patients had pre-op anemia. And again, they showed this dose-dependent relationship of anemia and mortality. In addition, longer length of stays. These patients who were anemic were more likely to be admitted to the ICU, more likely to be treated with both mechanical and non-invasive ventilation, more likely to end up on vasopressors or need more invasive procedures such as arterial line or central line placement. And then the meta-analysis comes about in 2015, looking at the presence of pre-op anemia in both surgical outcomes in non-cardiac surgery and cardiac surgery. And here's our forest plot that shows this as composite outcome of 30-day or in-hospital mortality according to the ortho-defined level of anemia. And the size of the markers indicate the weight for each study. So you can clear that overall they shift to the right side, which favors no pre-op anemia. Okay, great. I showed you that anemia is bad. Lower hemoglobin levels are bad. So I'll just fix the number and then I'm going to fix the patient, right? So this is actually looking at a retrospective cohort study from, again, this American College of Surgeons National Surgical Quality Improvement Program, looking at patients from 2011 to 13. And the primary objective of this study was actually to determine whether there was an association between varying degrees of anemia and transfusion with 30-day mortality. And they were trying to figure actually, was there a threshold that surgery should be delayed? So again, showed you that anemia is bad. That's our black lines here. But if we gave blood to make the numbers look better, you could actually see that the patients who got transfused actually did worse. So giving that blood transfusion did not improve outcomes and maybe actually made things even worse for the patients. And again, it's not just surgical patients. I worked in a combined medical surgical ICU. If we look at the broader population of all hospitalized patients, anemia and transfusion are associated with worse outcomes. This is actually a retrospective cohort study of tertiary hospital admissions in Western Australia. You'll hear about Western Australia data coming out a lot in the PBM literature. And they were looking at outcome measures in hospital mortality and length of stay. And again, clear relationship between worse outcomes and level of anemia. What I do want to note is much of hospital-acquired anemia is actually iatrogenic. So if the nadir, that lowest hemoglobin, is related to worse outcomes, then it's really on us, the clinicians, to help fix that underlying cause. Also of note, more than 1/3 of patients who are not anemic on admission developed anemia during admission. And that's a major statement, I think. And again, the red cell transfusion did not improve outcomes. And why is that happening? Why are these patients not getting better with transfusions? So here in the US, if I had a medical student, they could tell me the risks of hepatitis or HIV in the blood supply very easily. And they can even, the non-infectious things like medical errors, transfusion reactions, trial, TACO, they can list all those very easily. But when you start to ask them about immunomodulation, the effects on other organs such as the kidney, the prothrombotic, they start to stop a little bit there, and they don't have that sense of that there is continue to be serious effects from these blood transfusions. And this is kind of the area what the clinicians at Englewood were getting interested in, is that, there was more and more literature coming out about poor outcomes in patients being transfused. During this time period of liberal versus restrictive discussions, it actually, one of these papers showed that, hospital-acquired infections were actually much lower in the patients who didn't get transfused, who had low restrictive patterns. And they showed that number needed to treat to prevent one serious hospital-acquired infection was only 20, just by using restrictive transfusion processes. And just, interesting enough, like when you want to compare aspirin to prevent daily aspirin to prevent a heart attack, you need just around 60 patients. So this is even more effective than that. And again, I was been linking a little bit to the cancer survival. This is in our colorectal patients, but there's multiple studies in multiple different areas. These patients were followed for almost 5 years. So patients who die were 1.7 times more likely to have had a transfusion if they die within 5 years. Patients with serious post-op infections were 3.2 times more likely to have received a transfusion. My question is, how much effort are we doing to reduce the risk of exposure and focus on the patient's own blood health in our oncology patients? And I think also I've been alluding to this, is are transfusions really helping our patients at all? Or should we be focusing on something actually very different? This is a really, I think, excellent study coming out February 2022. And what these authors did is they used actually more of a business model for regression discontinuity analysis. And basically they were evaluating outcomes based on RBC exposure in patients with a hemoglobin concentrations of 6.9 versus 7.1. And I think we can all agree that clinically these patients are pretty similar, and their SOFA scores, their Apache scores were all very similar. But there was one big difference. Patients with a hemoglobin of 6.9 were much more likely to have been transfused than those with 7.1. And when we looked at outcomes, there was no improvement. And if anything, there was actually evidence that was swinging toward worse outcomes in those patients who have been transfused. So is 7 even the right number that we are treating? At Englewood, we're in the midst of we're doing our GI hemorrhage pathway. And what we, were classically trained was like someone's actively bleeding, try to keep their hemoglobin, closer to 8. And there's growing literature that actually, harm could be being caused actually for these patients, and that sticking with that restrictive transfusion was associated with lower risk. But again, I don't know, is 7 the right number? And, we still have to figure more of these things out. But I don't want to focus necessarily always completely on transfusions, because I actually think there's a way to step back and actually focus more on looking at patients' blood health. And one of the side effects will be improving outcomes by avoiding transfusions. So the goal of patient blood management is actually not to reduce blood transfusions or restrict the use of transfusions. Rather, the transfusion is really that default, moving away from that default decision based on a specific hemoglobin concentration. So a reduction in numbers of transfusions just follows as a direct result. So the same way we focus on cardiac health to avoid needs for, ending up in the OR with Dr. J, or even transplants or other devices, patient blood management really is going to be focusing on the blood health to avoid getting to that point where the patient is so sick that they need such other interventions. So as we're sitting here all having an international meeting, many of us are probably aware that in October 2021 that the WHO put out a call for the implementation of PBM programs. Very honored to have Dr. Sherry Ozawa moderating this session, as she's one of the people on the work group for the WHO right now, writing the recommendations. And this is, going to, here in the US, most likely end up leading to some government intervention coming down the road, is my guess. And we look internationally as well. This paper was very nice. It kind of explained where different countries are in their patient blood management development. The countries that are listed in green have, I would call, more advanced national PBM programs. Most of their literature is coming from these countries. And these are countries that probably have both a top-down and bottom-up leadership process. Personally, I find the data coming from Australia and Switzerland have been most applicable to my practice. Here in the US, the American Association of Blood Banking These are people who make their living off of transfused blood. They're even calling for reducing inappropriate and probably harmful transfusions as well. And why? Why is this growing call for aggressive patient blood management development, not just reducing transfusions, but really focusing on the multiple aspects of blood health? Because it improves patient outcomes and helps strengthen healthcare systems. And I'm sure many of us have seen this paper. It's a 2017 paper from Western Australia, which looked at over 600,000 patients, comparing their pre and post implementation of their statewide patient blood management program. And as you can see, there was a significant reduction in mortality, length of stay, hospital-acquired infections, thrombotic events such as stroke and MI. And they did this all while their case mix index was actually increasing, meaning that their patients got sicker. And as I'm going to show you next, there's similar studies in Europe showing similar outcomes. This was a 2019 meta-analysis of surgical patients before and after implementation of patient blood management protocols from 17 studies. And similar to Australia, they showed reduced transfusions, reduced complications, reduced mortality rates, all by after the implementation of a patient blood management program. So at Englewood, one of the things that we did bloodless really well, but what we really have to realize is what we're doing for our bloodless patients is actually really good medicine for all of our patients, and we need to transition this to everybody. So what are the components? How are we using perioperative patient blood management on a day-to-day basis for all of our patients? So the first, there are 4 main pillars of patient blood management here in the US. First one is managing anemia, then blood conservation modalities, optimizing coagulation, and lastly, but most importantly, probably patient-centered decision-making. With anemia, the first thing I always tell everyone is you actually have to identify the anemia. And that's sometimes still a challenge, even out in our outpatient setting, that to understand that hemoglobin 10 is not normal. Even if they've been told that they're going to be like that their whole life, you have to really evaluate what's going on. Thankfully, I work in an institution that has that top-down and bottom-up support. So there's actually hospital policies that no one can undergo major surgery that can have a significant blood loss unless their anemia is treated. An elective emergency, of course, can go. And that really, it's been accepted that a failure to identify and treat preoperative anemia can actually be seen as a patient safety failure. Preop anemia is very common, as I mentioned, in that European pre-op that they only had about 30%, but it really ranges 40% up to 90% rates of pre-op anemia for in vascular patients. It's extremely high. Many of it we probably treat on a normal day, patients with rheumatoid arthritis, inflammatory bowel disease, heart failure, renal failure. So extremely common that we see this. And I just want to note that most of these are actually usually due to irregularities in iron absorption and metabolism. So with the identification and workup, there are many different algorithms and methods, and depending on what lab test. So I don't want to dive deep into this, except that it has to be part of our program, that anemia is identified and that it's worked up and to figure out the underlying cause. And as I mentioned, a large part of this has to do with iron regulation. So just a little bit of a physiology review, that normal body iron regulation is really controlled by hepcidin. When our normal iron stores or levels in the plasma drop, the hepcidin levels will drop. Once your hepcidin levels drop, that allows iron to be absorbed in our gut and allows for our own stores of iron to be released from our reticuloendothelial cells. But probably like many of you, I treat patients who have chronic disease and inflammation occurring on a regular basis, or they've had surgery and now afterwards they have inflammation. And what happens is hepcidin is actually raised, or the levels increase when there's inflammation or chronic disease and you have hepcidin overproduction. Once you have high levels of hepcidin, they actually will block the absorption of iron from the gut and block the release of iron from stores. And if I can't absorb iron in the gut and I can't access my own internal stores, then how am I going to get iron to my bone marrow? And as Dr. Day mentioned, we use IV iron now. Now, traditionally, people were used to be very scared of IV iron due to allergic reactions from formulations, but really the safety has massively improved. Since we changed over to iron sucrose almost 9 years ago, we've actually not had a single allergic reaction in the ICU. Why are we using IV iron? First of all, they cost much less than erythropoietin stimulated agents. They also don't work appropriately without iron availability. These medications are very well tolerated. They work much faster than oral formulations. And, they work, we see 4 to 6 weeks, but honestly, we think with 14 days, we're starting to see effects. And even in effective inflammatory states, they work very well. How much iron should IV iron should we give? We start usually with the Ganzoni formula. There is literature to say that it might be underestimating the total need for iron for these patients, but I would say it's a good place to start. I also remind my patients that giving a unit of blood has iron as well. Everyone always says like, oh, if the patient's septic or things like that, don't give iron, even though there's actually no clinical support for that. But then if you ask them, would you give them blood? They would say yes. And I'm like, well, that has 250 milligrams of iron. Why aren't you worried about that? What's the issues with oral iron? First of all, very small amounts are absorbed on a daily basis. When you give oral iron, the following day, the hepcidin levels actually will rise and block any additional oral iron absorption. So multi-day dosing, everyday dosing, those are actually not going to be more effective. It's actually every other day would probably be ideal. But even then, with just the slow absorption, will take months to replete somebody. How long does it take to correct? We actually really didn't have great literature about this until recently, and it's probably an area that we need to improve upon. This is Nicole Gwynn and her team at Duke published this study in the fall of 2022. They looked at GYN and orthopedic pre-op patients who had gone through their anemia clinic, and they were able to show a significant reduction in transfusion rates in these patients. In addition, while not significant, there was clearly a trend for reduced lengths of stay, ICU admission, and readmission, but they were actually not powered to detect changes for that. And the median change in their hemoglobin was only 1.4 grams per deciliter, but they didn't have the most aggressive protocols. So on average, it was about 0.04 grams per deciliter today. So like our policy says 1 month is a suggested amount of time to evaluate, treat, and show an increase in hemoglobin. They actually, on their study, show that maybe we should bring up to 2 months, like 65 days before surgery to offer the best benefits of hemoglobin optimization. It's not just iron. Erythropoiesis, the formation of new red blood cells, erythropoietin is the main regulator of this process. And so we give the patient the building blocks, the construction supplies of iron, folic acid, B12, but then you need to bring in the contractor and get that bone marrow up and running. So, but unfortunately, chronic inflammation, the same way it affects hepcidin, also affects erythropoietin production and responsiveness. So we use a test called the reticulocyte percent, and we calculate reticulocyte index to see how well the bone marrow is functioning. Based on the level of anemia, index below 2 actually shows a hyperproliferative state, and that would make us consider the use of an erythropoietin stimulating agent, ESA. ESAs, as Dr. J said, they are more expensive than other medications, but actually cheaper than a unit of blood. And also, I always like to remind people that erythropoietin plays other roles in the body as well, affecting our vascular system, brain, heart, and wound healing as well. There really is not great consensus on dosing recommendations in the preoperative state. There are many quoted regimens, using between 20 and 40,000 units weekly, and even high doses. I always like to stress, though, you have to discuss the risks and benefits to thrombotic risk for these patients, and that especially also remembering that blood transfusions themselves are prothrombotic. And we do discuss sometimes patients on DV2 prophylaxis as we aim for normal hemoglobin levels preoperatively. Another question I always get when we're doing pre-op anemia management is, what levels are going to be okay for you? Normal. That's what we need. We want this patient to have their blood health. We want them to be normal, because all the studies have shown that when you get to normal, that's when you minimize the risks of everything that happens. Moving on to our second pillar of blood conservation. First of all, I am blessed to work with excellent surgeons and proceduralists. Working with people like Dr. J every day is extremely helpful. Having institutional support to buy the hemostatic devices and to train in different techniques. Communication and planning is extremely important. Anesthesiology, nursing, pharmacy, and then other techniques from the anesthesia point of view. Dr. J kind of hinted to some of these: acute normovolemic hemodilution, intraoperative cell recovery. So acute normovolemic hemodilution, This is a way to reduce overall blood loss and decrease the need for transfusions. Basically, what we do is we need a patient to start with a normal hemoglobin. So that's why the pre-op anemia management is so important. We will remove multiple units of whole blood from the patient, dilute the patient down, so all shed blood is much more dilute, and we have that whole blood kept on the side in case there is bleeding and need for factors or things like that, or for the end of the case. Some of the process, either we use a large bore venous or arterial line to do this. Literature says you need at least 2 units to be effective, but probably be higher amounts is really shown to be the more. There are really no changes in coagulation until you start to take off more than 1 liter of blood from these patients. There is no difference in literature showing which volume used to replace the whole blood that's been removed. And you do have to, at the end, especially if there's ongoing renal dysfunction and things like that, just be wary of the fluid overload with the replacement and thinking about the use of diuretics afterwards. The bottom here is multiple studies showing decreased exposure to allogeneic blood from using ANH. And this is standard for us in our open heart cases and our larger cases, such as liver resections or large spine cases and stuff. Moving on to cell salvage or cell recovery. In our hospital anesthesiology department runs the cell recovery, and we are lucky to have multiple devices available to us. Again, this is collecting shed blood from the patient, washing it and being able to reinfuse. Not all locations are able to have such access to expensive machines and devices. There are sterile suction canisters that can be kept in the operating room in case there's either bleeding that's expected or unexpected even, to be able to capture blood that could be heparinized until a machine can be brought in to an operating room. On the bottom right is a picture of that, the salmon colored disc. That's our leukocyte reducing filter that we use for more contaminated cases. Traditionally, many times people were thought that, you couldn't use cell salvage if the case was contaminated, like such as fecal contamination, or it was a cancer case or things like that. And really in Europe, the standard, is to use cell salvage still. And using leukocyte reducing filters could actually improve and remove the risk. Leukocyte reducing filters decreases the bacterial load by 99%. And just remember, like a bypass circuit has a 9% risk of bacterial contamination. Again, reduces the use of oncologic cells to be removed in leukocyte reducing filters and in obstetrics as well. Other methods of blood conservation: reducing the amount of blood we actually remove from the patient. My mentor, Dr. Shander, used to always say that the #1 cause of blood loss in the hospital was sunrise from daily labs. Phlebotomy can actually lead to significant blood loss. Literature shows that I showed before, between 1/3 to up to 50% of patients who come into the hospital non-anemic will develop anemia. And again, these are iatrogenic causes many of the times. Even the Society of Hospital Medicine says we need to dump the habit of daily labs. After 3 days, if the test results haven't really changed, we need to rethink why we're testing this. This is more about treating the clinician, not treating the patient, because it's not going to change outcomes. The third pillar, optimizing coagulation. Appropriate use of anticoagulants, understanding what is the real reason behind why someone's bleeding, having the appropriate reversal agents, and also thinking about how to make sure that the patient's clotting is the most appropriate it is. At Englewood, I've been very lucky that the hospital has invested in all the reversal agents. I do want to know, and we have appropriate policies to use them, but just a reminder, these are medications with very high costs and increased risk of thrombotic events. Many hospitals do use the 4-factor PCC off-label as a reversal agent. Another reminder is that there's currently no antiplatelet reversal agents, and platelet transfusion is really not usually an appropriate reversal agent either. If you think about like the patch trial for intracranial bleeds for patients on antiplatelet agents, actually the outcomes were worse in the patients who received platelet transfusions versus patients who did not. Viscoelastic testing, there are a bunch of players on the field, different machines out there. The original was a TEG, which had, the original was a whole blood with a pin suspended in a cup. They've actually moved to more resonance-based technology. Rotem in the middle was an immobile cup with the pin and wire were the ones moving. It was a little bit more, less sensitive actually to mechanical movement and things like that. And on the right side is some of the newer technology, Quantra, which is using ultrasound technology to measure cliff stiffness as well. You can't compare, there's no one gold standard, but there is multiple literature showing that if you use a method of viscoelastic testing, that you will improve use of outcomes in coagulation control and improving coagulopathy. And so here at Englewood, we actually recently had a project, a joint between anesthesia critical care and our hematology colleagues to really help with this physician decision support in the bleeding patient. Just remember, viscoelastic testing is really only validated for the use of in bleeding patients. There's really not great literature supporting it for predicting the risk of bleeding. Maybe in liver patients, there's some role for it. And as we're not a non-trauma center, we don't have any massive hemorrhages cases, so people are not used to necessarily always reading a TEG or a Rotem or a Quantra, so we found this to be very helpful. And this wasn't just about what units to, how much blood to give or blood products. This was really about thinking a bigger picture of how to control bleeding or how to strengthen the clot using antifibrinolytics and such. Moving on to antifibrinolytics, if you're ever looking for a great fun paper, this is actually an illustrated review of the use of TXA, goes through the history and the mechanism, and then also goes through the different trials and the level of recommendations based on level of quality. Recently, there was a nice review in Anesthesia and Analgesia about TXA, the current knowns and unknowns. And again, we know that in trauma, cardiac surgery, obstetrics, neurosurgery, orthopedics, that there is a good support for the use of that. Unfortunately, there have been some negative studies recently that we were hopeful that would maybe show improved outcomes. The HALT-IT, which showed that there was no effect in GI bleeding, or the use of preventative TXA in vaginal or C-section deliveries, but that didn't improve overall risks of bleeding. And moving on to the fourth pillar, this patient-centered decision-making. And really, instead of focusing on like transfusion triggers or specific numbers, really looking at the patient themselves individually, looking at their threshold and other larger issues, that kind of hinted to them, underlying diseases, socioeconomic challenges, are they getting enough appropriate nutrition in their life and such? I thought this was interesting. We look at patient centered care. Steve Frank at Hopkins put out this paper recently with a 4-year retrospective cohort study looking at a little over 1,100 bloodless patients versus 137,000 non-bloodless patients. And following the patient's wishes, nothing changed really. The length of stay and mortality was the same in both cohorts. Actually, in their medical bloodless cohort, they actually had lower hospital-acquired infections, almost half. And overall, the patients who received bloodless care had overall total less costs. I'm sure if you walked into the head of your hospital and said, hey, I can help you reduce 8% of your hospital charges, they might be interested in hearing. At Englewood, our bloodless medicine program is very extensive. We have a very well thought out educational process that the patients have to go through in order to be enrolled. They complete a legal advance directive and that can be updated as well, but this is something that cannot be overridden by anybody. And there's a top-down, bottom-up support, again, clinical and nursing education, notifications in our electronic medical records. The patients can be easily identified from ID bands and notices on their chart, flags in the, in our medical records, and ongoing support for research. Just so you have an idea of, some of our patients, This is from last year. We got about 700 new patient referrals. We do multiple phone consultations with other hospitals. And our number of inpatients, are staying the same, even though we're doing more and more surgeries. But I think because patients don't have to stay in the hospital overnight, we had over 29,000 outpatient visits from our bloodless patients last year. One of the things that we get a lot of reaching out is how to manage severe anemia. And this is, again, focusing on the patient in front of us rather than on what's the issues. What are the signs of end organ hypoxia or dysoxia that's going on? So for us, when we're dealing with these severe patients, we're thinking stopping the bleeding, blood loss, so there's no such thing as, oh, they're too unstable because they're bleeding. No, you need to stop the bleeding to get the patient to become stable. Addressing the coagulopathy, do we reverse everything? Are we giving them antifibrolytics? Are we replacing any factors of fibrinogen these patients need, and helping them tolerate this anemia? Really, this anemia tolerance, there's no such thing as a transfusion trigger. I think it's really looking at other signs of end organ hypoxia or dysoxia in that specific patient, looking at their mental status changes, EKG changes, their breathing, their renal function. But again, none of these include checking labs. You're just clinical thinking of these patients. And then we give them aggressive support for their own bone marrow to function, give them epogen and the building blocks, iron, folic acid, B12. And then flourishing this patient-centered care is when we retrospectively look at our own blood transfusion groups. We look at, was this a preventable blood transfusion? Are there things that we could do better to focus on the patient's blood health to improve outcomes? Other things that we're doing, as I mentioned, this Bloodless Medicine decision support app that helps patients when we have an emergency to figure out what are the next steps. And if you're interested overall in this topic, I think these are some of the things that should be coming down the road. Hypoxia-inducible factors, the yellow stuff, plasmaplatelet cryo, and other factor concentrates, coagulation anemia clinics. And of course, I am representing some amazing people. Thank you to some my mentors and leadership who continue to support me doing this. The ICU team are just phenomenal and happily, help with many of these middle of the night phone calls from other places and accepting patients from other hospitals who aren't comfortable caring for them. And then the amazing anesthesia department, and then the bloodless medicine department, people who are so dedicated 24/7 to supporting not just our bloodless patients, but all patients, to ensuring that they have the best high quality care. And as always, we're here to help. That brings us to the end of my presentation.